And I see this is one of the few cancers where I think there are internationally multiple kind of, you can say, guidelines. And apart from that, between surgeons, interventional radiologist and medical oncologist, even more disagreement. So let's see what our panelists have to say. So I think this is the basic BCLC goals, BCLC and the ESMO, and that for unresectable HCC, the in the BCLC, the first line is atezolizumab or durva tremelimumab, and if not feasible, which is a large number of our patients, then sorafenib or lenvatinib. Also single agent durvalumab. And ESMO has not put up the STRIDE regimen as yet, is 2021 update. And the treatment goals for the BCLC-B are potential try for cure, whereas for the BCLC-C to prolong the OS with as many lines as possible as we can manage. So with that background, let's go to this case. He's a 72-year-old fit gentleman, not hepatitis carrier, chronic alcohol consumption, and on routine medical checkup, he is found to have very high alpha fetoprotein level. He is asymptomatic, however. These are the images provided to me. Basically, I would say that this is a large tumor. The largest one is 73.6 mm, and there is other one also. So let's see. Yeah, and the LFTs showing child pug A with no ascites, no encephalopathy. And this is a BCLC intermediate stage, and as per the BCLC, the kind of the basic chart they give, chemoembolization would be recommended, but I'm sure there will be disagreement. So let's okay, now before we go to the options discussion, does anyone in the panel take performance status into account when planning the treatment? Yes, Dr. Akash.
So definitely in every patient, I take into account the performance status of the patient, because I decide treatment based on the performance status, and it is a part of the BCLC staging also.
Right. So it is there, but the reason I asked is that whenever I hear the discussions, it is generally about what is the size, what is this. I hope people are taking it into account and not discussing, but my concern is that it is not given the due importance. So
see how treatment actually on the first tense, patient is coming in the OPD walking on wheelchair, or patient is lying down in the dressing room. Depends on that our treatment plan starts. So
great.
I would like to add one thing. Not only the doctors, even the patient's families also take performance status into account. A patient who is bedridden, the family would uprightly say that, okay, we don't want to go for any therapy or any treatment or any surgery. So performance status is the basic thing for whether it is a surgical treatment or medical treatment.
So the extreme ones are okay, but what happens is these 2 and 3s kind of, where PS2 and 3 ECOG, where the relatives are also trying to push you that no, he is fit, he is walking, he does take care of his things, he's occasionally going out, kind of, they would try to convince you. And the physicians also, that immunotherapy, there is this feeling that it is very safe for everybody, and targeted therapy. It's not chemotherapy means it's all good. So I just wanted to highlight this part, that the BCLC also takes into account the performance status, and that is important. So now what will be the outcome of the tumor board meeting? These are the various options, and how would we go about? Everyone can answer, please.
Sir, this is a case in which there are multiple lesions in both the lobes, and the largest lesion is somewhat large, means 7.3 centimeter. Ideally, we can go for TACE, transarterial chemoembolization, for some of the bigger lesions, followed by immunotherapy, means immunotherapy plus targeted therapy, that is atezolizumab. That is what I would prefer. Prior to atezolizumab, obviously we'll go for endoscopy, and this is because post test I have seen in most of the patients that there is a recurrence. The data would say that the recurrence occurs 3 to 5 years. In fact, in this multifocal case, we are even otherwise not going to treat all the cases with TACE, all the lesions with TACE. Some of the larger lesions would be managed. But even if there were only 2 lesions or a single lesion and TACE was given, I would usually accompany it with atezolizumab, because there is almost always a recurrence followed by TACE, and that is not in 3 to 5 years. I've usually seen in 1 year or maybe in a smaller duration.
So let's quickly hear everybody's opinions.
So we have started do biopsy in all the cases, taking lead from Dr. Biraj, and we definitely will discuss in our board. And
Sorry, you said you biopsy every patient,
we have started to biopsy
even
all
with
this.
10,000 AFP.
Yes,
Okay.
maybe for the same reason that you put, maybe for later NGS or something is there.
Sorry, for the?
Maybe for the molecular studies later.
Okay. But in terms of treatment, what would you offer this
Treatment,
patient?
We'll send to our interventional radiologist. Let him take a. If he feels there is extensive involvement, cannot do anything, probably we will go for systemic therapy. If he feels some form of local therapy is possible, so we opt for it.
Okay.
Sir, I missed vessels are okay.
Vessels are okay, yes.
So my first plan will be TACE plus lenvatinib. That will be my first plan. And if too much heroism is going on, then TACE followed by once patient recovers. So many times post TACE, actually patient goes in some liver failure, and because remaining parenchyma also will get hit. And then atezolizumab for transplant if it's possible.
So in continuation after this, or when fails?
Once patient, no, continuation. Not
Continuation.
patient. Patient usually fails. Within few months only patient will fail.
Okay, so you are saying in a planned manner after TACE plus lenvatinib, at what point you would give atezolizumab?
No, if for me it's a TACE plus lenvatinib only. If
Okay.
in tumor board, if there is a decision that we may consider this patient for the transplant later on, then
Okay, that way, right?
then
right.
IO plus TKI.
All right, okay.
Sir, 2-3 things you have to keep in mind. One, PET is not done. PET is not reported here. Because AFP is high, there is high chances of systemic mets. So much high AFP is usually not seen. If it is local only, then probably we will try to cover it up with a TACE and then probably a transplant, because we have a transplant specialist. And definitely transplant is a cure. Not only he is available, but definitely we do know that 50% overall survival with transplant only you can get. Otherwise everything, whatever we do, having the best therapy, we will not be able to think of reaching 5 years. This is my take. And second thing, we will probably involve GI specialist, because bilirubin is 12. All the patient by report doesn't look like BCLC-B and Child-Pugh. So bilirubin only is 12. So LB has to be kept in mind. So these few things has to be kept in mind.
After discussion in MDT, if there is any scope of transplant in future, we would definitely like to conversion therapy in form of atezolizumab, followed by again reassess every 3 monthly or in between.
Actually, the
I should have
biggest,
started from this end, I think, because everybody is.
So I just have a question. The bilirubin that was mentioned, the unit, whether it is gram per DL or whether it is milligram per DL, because you have mentioned that it is child A.
Yeah.
If the bilirubin is 12, then the patient would be child B.
B9.
So let's assume this is Child-Pugh. The slides have been given by Roche, but for practical purpose, let's this Child-Pugh.
So basically, if you had asked this question maybe a few years back, then there would be only two options. One would be a loco-regional therapy, followed by reassessment whether the patient, whether the tumor is operable or not, and then go ahead with the transplant. But immunotherapy actually, and thanks to Dr. Viraj, I have seen some fantastic results in a couple of patients. So that is a game changer nowadays, and that is why I would like to consider immunotherapy as a part of the treatment modality in this patient, because over the time, in my personal experience, I have learned that sorafenib, lenvatinib, I have not found very good results, although my experience with the oncology is limited in HCC, but I have not got very good results. But immunotherapy, yes, I would like to consider in this case. TACE, I don't know how much effective it would be because of the size of the tumor. Normally, according to different practices, some people do not do TACE beyond 5 centimeter of size. So that is one of the factors which we need to consider. And yes, I would like to bring immunotherapy in this patient.
So I think this is one point you just made, is that TACE, the size and various criteria is still controversial about multiple ways to assess this. One of this rule up to 7 criteria, where this size more than 7 is likely to be less effective. So again, MDT required here. But just going back to the liver transplant option. So if you think liver transplant is an option, then would you allow TACE, say one session, 2 sessions of TACE, then maybe 3 years, 4 years we can go with TACE and leave the liver transplant for a later stage? Is that something kind of middle way? Would you consider that?
See, considering the AFP value, which is very high, so and another thing is, see, as transplant surgeons, we are generally not very happy with TACE because they generally mess up the arteries, so which are very important for the surgeries. But yes, if there are no other options, then I may consider TACE. But this patient, I am looking at the curative intent, and that is why I would like to be aggressive and would refer my patient to an oncologist for immunotherapy and then go ahead with transplant.
Thank you. For bringing that point. I did want you to say this, that don't mess up or whatever you call it, but ultimately there is this risk as well as reducing the liver function reserve and potential for metastasis over this waiting period of 3-4 years. So if there is a scope for liver transplant, then at least that should be discussed with patient first, because this is a big treatment, so not everybody would be willing for transplant and they may want to go for a slow treatment. Dr. Akash.
Yes, sir. So if you are planning for transplant from day one, if we are planning for transplant, so are you okay that TACE should be done, because the systemic treatment will make that result if we want some bridge therapy, so or it will disturb?
No, I'm okay with the TACE. It's not like, see, TACE, we routinely, we have done transplants in many patients after TACE. TACE definitely helps in reducing the size of the tumor and bringing it within the standard criteria for transplant. So it is kind of a bridging therapy. And up to some size, definitely up to 5 centimeter size, we have found excellent results in TACE and we are able to do the transplant. In this case, actually, size is also a problem. So what I am saying is, I am not sure whether TACE alone will produce results. So TACE with systemic therapy, yes, I would definitely give it a go. And I would like to bring the tumor within the transplant criteria and go ahead with the transplant.
Okay, so I think it is important to know that there is a lot of controversy here and it's not so clear cut, and this is without bringing the patient into discussion as yet. So patient may have their own choices. So this patient was started on atezolizumab based on the high tumor burden and consistent reproducible results across pivotal studies. So what has been the panelist experience in selecting first line therapy, and what are your thoughts about the major trials, and whether you feel that the trials and the real world, the patients that you see, are how similar they are or dissimilar?
So definitely they are not the same. Trial population eligibility, what we see in the OPD are different. As we have started the discussion, performance status, comorbidities, ongoing medications, whether they are on immunosuppressions or not. Those are the deciding factors on the basis of which we usually decide.
Right. Anyone?
Sir, actually, remnant liver is a problem, probably what you see. All the patient we see in at least child book B, not in A, means very rarely.
Albumin.
In child book B,
Right.
that's the problem. Second thing, the trials, only trial after sorafenib, which change the difference of the atezolizumab. In between, we have so many drugs, but there was no overall survival advantage, which atezolizumab was given. And the criteria which they use, like major vessel involvement, which we usually see portal vein thrombus, is only involved in that trial. So probably that is more near to the real world. This is what I can say.
So for now, first line we have multiple options available. Start from the lenvatinib and all the IO, TKI, now IO. So we have seen few good patients with only lenvatinib also past few years. So obviously not as a first line today if everything is possible. We are very okay with atezolizumab. So when there is no contraindication and there is no varices, no bleeding, no hypertension, then obviously most of the patients will be started on atezolizumab only. And Tremi Durva, if there is varices, that was the option, and it is the option. And if you don't want to give Tremi, then only durvalumab is also one good option. Not much difference in the survival if single agent, same Himalaya trial 1 arm. And now option is Nivo EP, this IO, and there is a good CR rate. At least we have seen in other malignancies. If patient achieves, then it goes on like years, 2 years, 3. Patient is going on now. And at least I have seen the 50% of patients actually they go on with ipilimumab also. That one of my patient is going on 2 years past and patient is on Nivo EP. Still
Yes,
alternate.
RCC you're talking
Not no, patient is having actually squamous cell carcinoma esophagus.
Okay.
Patient is going
So,
on CR.
right. So let's stick to
But
data
no
here.
means the problem of Nivo EP here actually they discuss about the side effects. So it's toxic and 25% discontinue the treatment. But I don't know why they have taken the ulta dose, means ipilimumab is 3 milligram and nivolumab is 1 milligram. So for that toxicity is increased. So that we don't know. But that is also one option, and I think if we get CR, then prolonged CR we might get in HCC also.
Right. So I think you have discussed a number of the aspects, but let's just any comments from Dr. Goel?
So, adding on to the previous question, the thing is, what I'm looking at is the vascular involvement, no varices, no bleeding diathesis, and again the rapidity of response. So it doesn't matter. What I'm not looking at this point of time, the etiology. So I'm going to segregate my patient based on the viral etiology versus the fatty liver or the NASH. Maybe the data exists, but I'm not going to segregate. Probably that's what we want. We want minimum toxicity and the widest of the impact which needs to be given.
So I think, as we are talking about comparison of the trials, this is one comparison, of course, cross-trial comparison, but just to have the concerns that we have as clinician, that we want rapid response, and as you can see here, in the first one, I don't know if the cursor is there. So, well, it's not moving there, but the top curve, the separation is at 1 to 2 months with atezolizumab versus the stride regimen, the separation is about 6 months. So, a number of patients, we would be worried that 6 months is a pretty long time, and the Nivo EP is even a crossover first of the curves and then separating. So kind of means that if patient cannot survive the first 6 to 12 months, if it is that much disease load, then this would be a worrisome. And okay. So other than that, I think there is a consistent separation. The other difference with the other trials and atezolizumab, is that IMBRAVE 150 had VP4 and high risk patients included. The others have not included the vascular involvement, which is an important criteria, and that clearly makes the patient high risk. And the need for significant steroid high dose in both NEO-EP and the STRIDE regimen in HCC patients with poor liver reserve, fluid retention, and many other issues to treat them with high dose steroids. So atezobev has been compared kind of across trial as to where it would be likely to be better. So against sorafenib, lenvatinib in terms of the survival, and not against durvalumab, at least in the cross trial comparison. The three factors that we just discussed: the high response, we want a quicker response, deeper and long lasting. And so now the question was raised about atezobev, can it be used in patients with varices? So anyone, yeah, please comment.
If properly treated, maybe if addressed, probably
Okay.
we can add. In unselected population also, the risk of bleed was there. Close to 1/4 of patients had serious variceal bleed. But if the varices have been addressed, probably we can add.
So as far as I remember, the IMBRAVE 150 did not require everybody to have screening upper GI
So I
score.
did not require, but 26% of the patients had bleed
6
in that
months.
study.
6 months, I mean, if any variceal bleeding was there, patient should have at least 6 months should be passed.
So I will, yeah. So the analysis of the patients from this study with varices and without varices, as you can see, the survival between the sorafenib and atezobev with varices also has been better. OS, PFS, and without varices also nearly equal. So it seems like it did not make a huge difference. And the bleeding, the sites, if you see, 25% total bleeding versus 17% with sorafenib. So the number is not huge difference, and out of which the esophageal varices grade 3 is only 1.8%. Rest are epistaxis, hematuria, gingival bleeding, and other which you would not be worried about. So I think maybe it is important to consider, but not to think too much about varices as a contraindication unless they are untreated, very severe, and if there is no bleeding in the past 6 months, then I don't think we should worry too much about it.
Yeah, sorafenib is also anti-VEGF. So in that we were not too much worried about those parts. And obviously
Right.
bleeding incidents we see more in BEV, but both are anti-VEGF. So we should check for all the patients once banding is done, and then we can go ahead.
So, yes.
Or you stop, or what you do? Of course, you will treat the
I
bleeding.
have expert panelists, so
Yes, sir. So I would at least I would like to stop it. Obviously, if bending is possible and if bleeding is stopped, stop BEV for a few seconds. Patient is nicely responding. Continue atizo and restart bevacizumab once there is no bleeding.
So you will restart after what, 6 months, 3 months?
No, within 2 to 3
any
months.
other opinion quickly?
Is it safe to re-challenge atezobev when there is an episode of bleeding which is proven due to varices, which we have treated? Because obviously, if there is a bleeding, you will treat. But can you re-challenge?
So variceal bleeding, I will not re-challenge.
So I don't have a answer
Sir,
from the data, but I would say that if the bleeding is significant enough, then I would not re-challenge.
Okay, so how will you define that significant? That means
So significant, which means requires hospitalization and procedure.
okay. Because the problem is that, as he said, that we may continue only atezo, and as Vikas also pointed out, whether single agent atezo is effective, because we don't know then atezo-bev what is working, whether it is atezo working or bev working, or because of the bev atezo is working.
Absolutely, very.
So I would like to add
good
two
question.
things. May I add two things in this case?
Yes, please.
So one is any variceal bleed is significant and patient has to be hospitalized for
Correct.
that. Second is maybe this immunotherapy may be restarted once all the varices have been obliterated. Although in the bleeding naive patient who has never had bleeding, okay, fine, we are not much worried about it. But once a patient has variceal bleed on immunotherapy, I would like to obliterate all the varices, which generally takes 1 or 2 sessions of endotherapy.
So after
And
that,
then
you rechallenge.
after that, why don't? Once the varices are obliterated, then the risk of bleeding generally comes down to a significant level.
At least there is no literature data to say that we can re-challenge. Most of us don't re-challenge in the practice.
So, because we are allowed to start BEV when there are varices which are
No,
treated.
we have started when there is no varices, but in the
but,
course.
but
patient
we
may
are
develop.
allowed to start if there are varices which are
Okay.
treated and they have not bled even before treatment in last 6 months. The trial or otherwise is allowed to start BEV. So kind of same argument that after treatment you may consider.
Okay.
So
Fine, thank you.
So I think this was mentioned by one of the panelists that viral or non-viral, it doesn't matter in terms of the data. And there have been efforts at kind of subset analysis, but nothing very clear cut. And it is, as you all know, that subset analysis are more hypothesis generating for next trial, but not conclusive by itself, and that should not be taken as a standard of care based on those. Across the etiologies, the efficacy was seen in non-viral hepatitis B and hepatitis C, all 3 cases. So even for the metabolic disorder versus viral etiologies, there was no difference in the efficacy. How has been your real world experience with atezo plus BEV? Very quickly, last few minutes. So,
Sir, it has been quite variable. Means if I just take 5 different types of patients, one with vascular involvement, one multifocal, one with extensive meds, somewhat with liver failure, one of a very benign nature, CPA, and one other patient. There have been different outcomes. Means one patient has gone on to survive for maybe 3 years or more than that. One patient had rapid deterioration with immunotherapy related side effects, developing muscular weakness, dysphagia, and other problems, and rapidly deteriorating, and then I lost him. Then there are patients, there is patient who would survive only for 1 year. In one patient, I had variceal bleed, even after having done ligation and everything was fine. So there are different outcomes. It is not very uniform, and there is a set where there is almost no response to treatment. So the overall response rate is not very high. Only about 40% of patients respond. Some may respond for a longer duration, some for a shorter duration, and then this variable.
next person.
So, sir, this response rate is 30%. So it's not extraordinary regime at all. With stride also they have given its response rate 45-50%, but still most of the patient you have shown the separation of graph, but we have seen means it's so many patient falls initially only. So it's not an extraordinary regime, but yes, better than sorafenib and now lenvatinib. It is little better, but not very happy, I would say, because of the disease only.
No, yes, I want to hear all the
So here
experiences.
we have to see that how other part of liver is working. That is also important, because I have seen the patients who are falling early, they have very less liver working. So that is also should be taken in mind.
Okay.
Agree, sir. Whoever progresses usually progress initial 6 months or so.
All right. Yes, we have crossed time. So thank you very much. Thank you all the panelists.